Hi, Dr. Pelto here. I'm going to do a staff training today, staff and doctors training about all the office procedures that we do uh, and all the treatments that we do. I'm going to go over. It's kind of a comprehensive uh, explanation, but I think many people just don't know exactly what the treatments are. This can be for the back office staff so they know kind of what we're doing, and also for the front office when people are checking out and they're getting these procedures. So we're going to go over all of these procedures. They're in alphabetical order. I'm going to put a link in a lot of these. There's going to be these little links where you can learn more if you want to. These are going to go to different Google patient education things that we do. So let's start out. Aspiration of a cyst. This is where there is a cyst in the foot. Usually it's coming from a joint or a tendon sheath. It looks like a big bulb on the skin. It can be in different places. To aspirate it or to take out the liquid prevent, we use anesthesia. So we anesthetize the area. Usually it's right on the top of the skin, right over it first. And usually 1 cc is enough. And then what we do is we take an 18 gauge needle with the same syringe or a bigger syringe, usually 3 to 5 or 10 cc syringes, and you pull out all the liquid that's in there, and that should deflate this. This can be sometimes done with ultrasound. And then afterwards, you apply compression, a 1 to a 3-inch Coban. 1 inch tends to be for toes, 3-inch tends to be for the foot, and they'll keep that on there for repeating it once a day after they shower for 2 weeks. And then you usually do a 2-week follow-up for this. That's what a cyst removal, how that is in the foot. There's a high chance of recurrence with cyst removals. And if it doesn't resolve doing it like 2 or 3 times, then a lot of times we'll surgically remove the cyst. But even with surgery, there's a high recurrence rate. Next thing would be biopsy of the skin. Many of our patients, they have skin dermatitises or athlete's foot or tinea pedis or eczema or other types of things that haven't resolved. They may have tried something topically already, like an antifungal cream. What we tend to do for skin is we do 1 cc of lidocaine with epinephrine. The reason for the epinephrine is because it doesn't bleed as much. So you would just put a little bit of a little bit underneath. Usually you want to do the edge of the area that you're going to biopsy. And you do two 2 millimeter punch biopsies. That's the easiest for most. The reason 2 millimeters are done is because you don't need to do a suture. Many times with 3 millimeters or 4 millimeters, you have to put a stitch in there. So it's just easier to do 2 of them, and they heal a little bit better, and they give you 2 different parts of this area. You use it to identify any dermatitis, athlete's foot rashes. You may try something topically before, but if that doesn't work, then you can do this. I usually do a 2-week follow-up where I go over the results and you make sure everything heals. Normally these heal pretty well. This is one type of a biopsy. We're going to go over a few other types of biopsies as well. This is from a previous lecture. It talks about CPT codes. If we do 2 of them, you have to do an initial CPT and then the subsequent biopsy. Here are some reasons that we would do it, and some of the things we talked about before. It's usually a smaller part of a larger lesion. This is how you do it. You kind of go down, you punch it in there. Be careful when you're removing it from the plunger right here to not crush it. It goes in from formalin. They're full thickness. They're going to heal by what we call secondary intention, which means they heal just on their own. If it's over 3 millimeters, then you usually do a suture. For pigmented lesions, which are like things we're worried about, melanoma, you're going to do a larger biopsy can be used, and you have to mark the position on the foot. You might take a picture. You might take a suture and put a suture in the biopsy site to determine what's anterior, posterior, in what time. Usually like 12 o'clock, 3 o'clock, whatever o'clock it is if you're doing that. We also can use curettage. That's using a curette. This is typically used between the toes. So if there's a buildup in there, white buildup, it could be athlete's foot, could be another condition called erythrasma. And we test this with a Woods lamp where you take there's a little black blue light that we have, and it makes it fluorescent. You scrape the surface and you can send it off. There's no need for anesthesia, but it's It's difficult to get anything deep with that, so we just usually use this between the toes. There's another couple of options of doing shave biopsies. We do less shave biopsies. If there's a lesion we're removing, it's usually we're cutting out a wart, which shave doesn't usually get deep enough, but this could be for little elevations in the skin. You can get the whole lesion out. Usually we use the 15 blade. This is called it's like a flexible blade. I think we have some of these in the office that you can use as well. A nail biopsy. This is done right here. Here's an example of a 3 millimeter biopsy that we did. This is after, like a few months after, because it's growing out, and it's used to evaluate melanonychia. This is a black line in the toe nail. If we're concerned about melanoma, we will do a biopsy at the nail base. You do a block of the toe, meaning you numb up the toe in the back, just like you would do for an ingrown toenail. For nail biopsy, we usually do a bigger one, so a 3 millimeter one, but we don't need to do a suture. You're going to evaluate, you do a 2-week follow-up, and usually this grows out well without injuring the growth plate. With a nail biopsy, that's normally for dark discoloration. Just a reminder, nail samples aren't considered biopsies, so taking a sample for fungus isn't a biopsy. You're usually doing a toe block for that. A nail sample, this is what we typically do in the office. We use it to evaluate nail fungus for discolored nails. What I tend to do is when the patients have their name on a little piece of paper, I just take that paper, stick it onto a little plastic bag that we have in the bottom drawers, and I take a little trimming. So I would trim distally here on the nail, put it in the plastic bag, put what toe it is, and I would fill out the biopsy within the medical record. So you always have to put it in the medical record what area you're doing, and then that's sent out, and I put their name on there from the little Post-it notes that we use. This isn't considered a biopsy. I tend to see patients back in 2 weeks where I would go over the results with them. Even though many times we think it's fungus, a lot of times it can be due to trauma or to other things. So it's not always a fungus. That's the reason we take the nail sample. And especially if I'm going to be putting someone on oral medication, I like to use a nail sample. Very rarely we do this as well. This would be a needle aspiration. So we talked about a cyst before. With a cyst, you could biopsy that. So you could use imaging, which would be ultrasound, for a soft tissue lipoma or a ganglion cyst. If you don't get anything, then you would just flush out with the specimen jar. So let's say you try to pull something out of a soft tissue mass, but you can't get anything out. You can still take what's in there and you kind of draw up the formalin and you push it back in, and that could put in some of the contents. So you can send that. You have to create back pressure or a vacuum. You can see how it's pulled out with the fingers right here. You're pulling it out. That's creating back pressure as you're pulling it. You go into different quadrants because many times these lesions are what we call lobulated. So there's different little chambers in them. So as you're pulling it out, you're pulling out for the quadrants. If you don't see anything, once again, you drop the fixative, which is the formalin, and you squirt it back in the specimen container. So that's what we do for these aspirations of soft tissue masses. Okay. Other procedures that we do, there's a procedure, we call it a procedure, but it's brace dispensing. So that's done with a doctor. This is a visit with the doctor when we're dispensing the brace. The reason we do it with the doctor is because we want to make sure it fits. We want to make sure they have the right shoes. And we also bill the insurance at that visit. So we don't bill it when we order it. We bill the insurance when we dispense it. You need to make sure it fits well. Giving them shoe guidance is of the utmost importance. We give them a handout that has some information about shoes, but typically they have to go up a half size. And they also may need to do an extra depth shoe or something similar. These patients tend to be in like an orthofeed or a Dr. Comfort shoe or a depth shoe or something that's a little bit bigger. One thing to remember, patients have a 6-week follow-up, and you have to be careful of any rubbing. So if there's any rubbing on the skin, you have to be careful. They should be seen back sooner. And they can get a new brace every 5 years unless their foot changes. So if their foot gets more collapsed, it gets more swollen, increased deformity where things don't fit, then you can evaluate something called same and similar and try to get a brace that's newer. This is an example of a Ritchie brace for a patient. You have to be careful that there's no rubbing with these. That's especially important if a patient is diabetic or neuropathic. Casting, this is something that we do frequently post-operatively. There's a little cast stand that we use, so all the materials should be prepared. It's done in the office. Sometimes patients might come in with a bivalve cast. That just means it's cut down the side, and then you put an ACE wrap around it. That's to allow for more swelling initially, but then when we put a cast on, we'll put it on and take it off every week to 2, depending on the amount of swelling. If they have a lot of swelling, you'll take it off in a week because the swelling will come down with the cast, and it'll piston, meaning it'll move up and down, and that could cause irritation. Usually we use 3 rolls of cast material, and we use the cast stand. Sometimes we'll put a little peg underneath it to help the patient. This is done by the doctor, but the setup is done by the staff. Focused shockwave. There are 2 different types of shockwave we have in our Westboro office. We have the focused and the radial. I'll talk about all of them here. So the difference between focused and radial focused is electrical waves. It has very good bone penetration, and it's used to speed up healings of fractures, stress fractures, areas that have bone marrow edema. That's noted on an MRI. It can help with arthritis pain, but it doesn't restore the cartilage. So it can help with the swelling underneath the bone marrow edema. It uses electrical pulses. It can be done by itself if it's purely a bone issue, but many times it's done with radial shockwave. And here is radial shockwave. This one has a little piece of metal that goes back and forth here, and it creates these radial shockwaves that penetrate into the skin. It's used to help areas of chronic or acute injury. It can be used for chronic issues like plantar fasciitis, Achilles tendonitis, other types of tendons. It tends to work really well on soft tissue, and also can be used for acute things like an ankle sprains and things like that as well. Hips. The way I kind of explain it to patients is it helps speed up the healing process by 50%, and it's 82%. I know Dr. Sabiet says like 89% effective. Depends on what it is. Very, very rarely is it ineffective. It's not usually used in isolation, so you're doing other treatments as well. It's good for plantar fasciitis, Achilles, tendon issues, swelling, ankle sprains, neuropathy, arthritis. Not so successful for neuropathy and arthritis as the other things. Usually you do 3 to 6 sessions. The way I kind of explain to patients, if it's been over 6 months, I say they'll probably need 6 sessions. If it's under 6 months, they'll need 3. Some of the doctors go right to 4. It really depends, but some of these chronic issues, you need more time, and it takes about 6 weeks before they see improvement. So the benefit of doing 6 sessions is that when they come in at the 6th one, they start to feel better. So what I tend to find is after they finish, I'll say you'll start to have more good days than bad days. You can't have Motrin or similar medications for 2 days before and 2 days after, and we tend to do weekly appointments. It's kind of like going to the gym, so you don't want to do it once a month because you're not going to see the benefit. Like going to the gym, you should go every week because it's going to be tissue breakdown and tissue repair. So it can go up to 2 weeks, but usually it doesn't go beyond that. And it can even be sooner than weekly. It can be every 2 or 3 days as well if you want. The effects of shockwave, a couple of the most important things that we tell patients, it stimulates circulation. Okay, microcirculation is important to healing. You don't really need to know these other things. Release of substance P just means there's reduced pain in the tissues. It stimulates growth factors like new growth of blood vessels, bone, and cartilage, and it stimulates stem cells. So it recruits kind of the stem cells in that area. So it's not injecting stem cells, but it recruits that. That's why it heals things that aren't healing. And for patients, a lot of times they're walking on their foot and they just never have a chance to heal, or it keeps injuring it. So that's why we support it with like an orthotic or a brace or a boot. And then we use this treatment to help it heal faster. The shockwave process, initially we evaluate it, usually with an ultrasound so we can see the damaged tissue. We do 3 to 6 sessions. They're done weekly. They're 7 to 10 minutes, avoiding NSAIDs. A 6-week break. During this time, there's a repairing of the tissue. And this starts after 6 weeks. This is the time where I usually send them to physical therapy during that 6-week interval, and then I would see them back after 6 weeks, and we see the improvement. And if we want to, we can look at it with an ultrasound again. With ultrasound, I tend to charge for the first ultrasound, but I don't tend to charge for the subsequent ones if they're paying out of pocket. But if insurance covers it, then I'll bill it. And it takes about 6 months for everything to remodel. And so you just have to tell patients to be patient. Radial and focused, we tend to do together. It helps to speed up the healing. We only have both of these in Westboro right now. It can also be done with pain laser. There's also a pain laser that we have, Remy pain laser, so we could do all the combination. Talk a little bit about office visits. Just for simplicity, sometimes we'll be putting this on the notes, but just for kind of staff training. Typically for established patients, there's new patient visits and established. So established are anyone that hasn't has been here in new patients. Anyone hasn't seen this in more than 3 years. Okay. If it's been less than 3 years, it's an established patient. I kind of keep it simple. A level 2 visit is typically a quick follow-up where you're not really going in depth that much. This is very a high level overview here, but like a paronychia follow-up, matrix follow-up, infection follow-up when everything is doing well. Level 3 visit is where we spend most of our time, level 3 and level 4, for like a diabetic foot exam. Just a reminder, for a diabetic foot exam, we tend to put in the billing not diabetes, but normally the condition that we're looking at. So let's say they have diabetes, but they also have an ingrown toenail or hammer toe or something else like that. And when you need more treatment and the current treatment is not that simple. Let's say we order physical therapy, we order other types of treatment, we decide on shockwave, we decide on something else. Level 4 is more complex, or I kind of keep it if I'm doing a prescription. So if I'm doing an anti-inflammatory or antibiotic or something like that, or renewing a prescription, that's going to be a level 4. Or if you're doing like surgical discussion, which you're tending to do prescriptions or planning to do prescriptions at that time. So just a simple overview of some of the billing things. A benign lesion excision, which is like removing a wart. This is an example of a wart where we would numb it up with anesthetic with epinephrine, so there's no bleeding, and then we would excise that. That could be anything else. Many times for excisions, we'll use an Amerigel post-op kit. Post-op kits can be used not just on ingrown toenails, they can be used for like wart removals, they can be used for matrixectomies, they can be used for other wounds that aren't that deep. I tend to send anything we take out of the body, like a lesion, I'll tend to send to pathology. The only times I wouldn't, let's say they're like a self-pay patient and they would have to pay for that pathology evaluation, which can tend to be expensive. And then we'll do a 2-week follow-up for them. Here's an excision in nail and nail matrix, which we call a nail matrixectomy. That's what this is called. It's used for chronic ingrown toenails. Someone has a chronic issue. They might have swelling on the side, or they might just have callus buildup. What we do is we take out the edge and we put a chemical, which is in our office sodium hydroxide, and then that doesn't grow back. It's used to remove the side of the nail or even the entire nail if they don't like it due to a fungal nail. The common complications are infection, which is quite rare. It's not really that common. So I always tell patients there's going to be redness, there's going to be swelling down at the base. And a spicule can happen. This isn't a spicule. So spicule is a piece of nail that grows back after a matrixectomy because it didn't work completely, and you can remove that again and do another matrixectomy on there. We tend to do a 2 to 3 week follow-up. If you're less busy, you can do two in a 4 week. If you're busier, you can do 1 at 3 weeks. Okay, and then we also can have patients text us a number if they have concerns. This is an example of an exostectomy. An exostectomy is an area of bone. Usually it's between the 4th and 5th digits where it's kind of macerated and there's pain in there, usually due to a bone spur. And the treatment for this certainly is spacers, wider shoes. But then if that doesn't work, we shave down the bone. So you would shave down the bone on the side. We usually use a metallic marker when we get an x-ray for this to determine where the bone is. And then you would put you would just make a little incision on top or at the tip, and you would use the rasp to go in there and shave that down. And then that would kind of resolve that. You can't get it wet for 2 weeks because there's a stitch in there or a couple of stitches, and it's going to shave down the prominent bone. And we usually do a 2-week follow-up whenever there's stitches. And there might be a normal shoes or a surgical shoe after that. Example of a foreign body removal. Once again, this is if there's a non-infected one, such as like glass, it can be hair, a little pebble, a needle. You may or may not need anesthesia depending. Consider anesthesia with epinephrine so you can see it better. I tend to use, we're getting x-rays, once again, like a metallic marker. You put a metallic marker so you can see if there's anything underneath there. A lot of times you can't see it with an x-ray, so you may have to do an ultrasound to help you see better, and then tends to be a 2-week follow-up. If there's an infection, you would use an antibiotic. This is an infected foreign body or just an abscess. This tends to be a little bit more difficult. You would have to open it up with an incision, so you'd have to numb that up as well. You would flush it out, and you would give patients an antibiotic. Many times we would take a culture as well if we can't get all of it, or if we want to know what type of antibiotic to guide that. If it's large or deep, you would put them in a surgical shoe, and then you would use the post-op kit afterwards. Fracture care is just it's more of a billing thing, but when we see someone with a fracture, you can do this. So with fracture care, it's more of a billing issue. So if there's a fracture in the foot or the metatarsal or somewhere else, it increases the billing initially, but then at the follow-up visits, you don't do office visits, you only do x-rays unless there's a new condition. So if we see something like a stress fracture or there's a fracture, many times we'll do this and then we'll do a 2 or 4 week depending for the follow-up. And then if there's like they have plantar fasciitis that develops something else, then you could bill that. But normally you have a longer, what's called a global period in between this fracture care. Hardware removal, we don't do this that often in the office. Occasionally we'll take out a little screw. We used to do it more, but this is an example of a little screw, and you would do this with an x-ray, and you would just put a guide wire down there and pull out that screw. We don't do it all that often. You would put a couple of sutures in there. The most common ones we used to use were FRS, but that tended to strip in the office, so it made it a little bit hard. There's OsteoMed works a little bit easier because it has a different head of the screw. So occasionally we'll do that depending on patient's preference. Hematoma or incision and drainage of a blood underneath the nail. It can be used to drain this hematoma. Sometimes the nail will come off, and the entire nail can be avulsed. Whenever we're avulsing a nail, we tend to put some non-stick dressing on top of it because it really hurts to pull it off if it sticks on there. And with these, we also want to check many times with an x-ray to see if there's any fracture. Amnio injections. So amnio injections are used to help speed up healing of chronic tissue injury, very similar to the way that shockwave is done. But it can be used in areas that aren't typical for cortisone. So for example, the plantar fascia, you can use cortisone, but the Achilles tendon, you can't. And so this would be an area you could do it on the Achilles that's safe. I tend to immobilize the patients in a walking boot for 3 to 5 days after I do an amnio, just because it's kind of not because of the procedure, but because it's such an expensive treatment to put inside there. And I typically use it in conjunction with shockwave. So not by itself. I'll do, let's say, 3 shockwaves, and at the second visit, I will do amnio. Currently, we're using right ViaFlow, and you can expand it 3 to 1. So what that means is if you have they come in at half cc's. So you would do a half cc's of amnio, and then you would I tend to do 1.5 cc's of saline, and then a half cc of Marcaine. Okay, so it expands into 2 cc's total, or about, yeah. So I think it's 1 cc. Yeah, 1 cc of saline and a half cc of Marcaine for a little bit of numbing in there. The way I word it to patients is I say it helps stimulate your own stem cells to speed up healing, and it's safer than cortisone. That's kind of how I word it to the patients. And meditations, they want what's best, right? That's what our patients sometimes want, and so we can offer that. We can offer shockwave and the amnio as well. Cortisone injections, we still use cortisone. It can be used for fascia, tendon, joints, usually between 1 and 3 cc's. We pre-drop here in the office 3 cc's for our patients in case we need it. You might not have to use the whole thing. Like in certain joints that are smaller, you can't use the whole thing. Sometimes patients can develop called a steroid flare reaction, and I always tell them about that. It might get red, it might get swollen because it's a foreign substance in your body that you're not used to. It's very effective for patients that have a gout flare-up. Be careful if there's any signs of infection, though. It's not typically done in the Achilles region, and also we don't usually use it on the MPJs. So second MPJ, third MPJ, because it can cause weakening of the tissue and like hammertoe formation. Sometimes I will do it if I put them in a walking boot, or if I just warm them and there's nothing else that they don't want anything else, or if they've tried other things. You just have to be really careful. Because you could cause weakening or hammertoe or plantar plate tear or things like that. It's commonly done with ultrasound guidance, and in our hands now in the office, we tend to do less cortisone because we have the shockwave treatment. We tend not, patients always ask this, how many injections can I have? We tend to do no more than 3 injections in any location per year. So they can have 3 in the knee, 3 in the back, 3 in the foot, like 3 in the heel, 3 in the big toe joint. They can have 3 anywhere. Sometimes you can do more, but you just have to be careful if you do too many of them. Another area that we inject with cortisone is the neuroma. And you evaluate for the Mulder's sign. That's just where you squish the foot and it causes a clicking motion. Patients tend to say they have a fullness feeling, or they're walking on a bunched up sock. Injection can be done with an ultrasound. And then you kind of inject that area, that little bulb that you can see right here, 2 to 3 cc's of cortisone. If you're doing an ultrasound, you tend not to use as much because you can get it directly into the area. So we say like a drop is the same as a gallon. If you can get it in the right spot, you don't need as much. And we tend to do a 2-week follow-up for these neuroma injections. Other tendons that can be injected as well. This is an example at the base of the 5th metatarsal where the insertion of the peroneus brevis is. This is an ultrasound. You can see the inflammation. It can be done in any painful tendon, but once again, you have to be careful for tendon weakening. You might want to immobilize them in a walking boot or place an Una boot around the area to rest it, and typically done with ultrasound to see the area of damaged tissue. And you have to discuss the risks of rupture. And also the other option would be the shockwave, which we tend to do more so now than the cortisone. Things that we don't do that often, but I just want to talk quickly about injection of scars. So some patients come in with really painful scars. We can inject those painful or keloid scars with cortisone. Don't do it all that much. There are other things that you can use like silicone tape, something called Scar Guard, and other treatments include laser treatment, which we'll talk about a little bit later, that can reduce the thickness and the color in the area. I kind of think of scars similar to a plantar fibromas, which are those big lumps in the bottom of the foot. They're kind of treated this same way because they're proliferation of tissue. Keratomas, or just callousing, we trim them with a 15 blade. If there's bleeding underneath it, you have to be aware because normally the bleeding makes it an ulcer. So that would be it. And be careful between the toes. You could also have issues. And we tend to recommend a callus cream and a pumice. So patients are going to pumice in the shower and then use the callus cream afterward with padding. And many times they'll do orthotics and things like that. And if there's fissured skin, we'll use sleep and heal. So fissures are on the back. They'll use that sleep and heal, callus cream, and other things like that.